Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1.
Extract 1. Questions 1 to 12.
You hear a physician talking to a patient called Mr. James Williams. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, he's my father, and he had a septic shock. And when we consulted locally, the diagnosis revealed elevated cardiac enzyme profile. He had some workup done from cardiac standpoint, which has been negative so far.
Okay. Does he have any previous history of chest pain or shortness of breath?
No, doctor.
What is age?
58 years old, doctor.
Does he have any history of hypertension or diabetes mellitus?
No, doctor.
Does he smoke or drink?
No, doctor.
May I know his past medical history?
Well, he had pulmonary fibrosis, and he is on prednisone. Oxygen-dependent cellulitis, status post-foot surgery with infection, recuperating from the same. Respiratory acidosis, septicemia, and septic shock. Presently on mechanical ventilation. No prior cardiac history. Elevated cardiac enzyme profile.
He had any surgery earlier?
Yes, he had foot surgery.
Okay. What medicines he is taking now?
Vitamin supplementation, prednisone, cyclobenzaprine, losartan 50 mg daily, nifedipine 90 mg daily, Lasix, potassium supplementation.
Is he allergic to any medicine?
Yes, he's allergic to sulfa.
Well, his physical examination reports show pulse rate of 94, blood pressure of 98/57, respiratory rate as normal, air entry bilaterally clear, rails are scattered, point of maximal impulse displaced, S1, S2 regular, systolic murmur grade 2 of 6. There are chronic skin changes, markings in the lower extremities, pulses found palpable. His laboratory reports show echocardiogram is normal, sinus rhythm with wide complex, white blood count of 20,000, hemoglobin 10, and hematocrit 33, platelets of 163, international normalized ratio 1.36, BUN of 158, creatinine 8.7, potassium 7.3 of bicarbonate is 11, cardiac enzyme profile, troponin, 0.05, total creatine kinase, 312, myoglobin, 1423. Chest x-ray, no acute changes. He has pulmonary fibrosis and is on prednisone. Oxygen-dependent with respiratory acidosis. Septicemia, septic shock secondary to cellulitis of the leg. Acute renal shutdown. Elevated cardiac enzyme profile without prior cardiac history, possibly due to sepsis and also acute renal failure. I am ordering an echocardiogram to assess left ventricle function to rule out any cardiac valvular involvement. He needs aggressive medical management, including dialysis. From a cardiac standpoint, conservative treatment at this juncture. His cardiac enzyme profile could be elevated secondary to sepsis and also underlying renal failure. Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Mr. Greg Matthews. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, doctor, my husband. Actually, he fell down yesterday morning when he was trying to put his boots on top of the staircase. He fell down 20 steps and he has lost his consciousness. He was evaluated by a local clinic and was amnestic at the time of examination. A HCT scan was taken and thereafter they referred to your hospital.
Well, what's his age?
72, doctor.
Does he drink or smoke?
No, doctor.
May I know his past medical history?
Well, he had atrial fibrillation, right hemisphere stroke last year with associated left hemiparesis and amaurosis fugax. This was followed by a right coronary artery for 98% stenosis. However, the stroke symptoms and signs were resolved. Degenerative joint disease, total replacement of right knee 2 years ago, venous stasis with no history of deep vein thrombosis.
What medications is he taking?
Lasix 40 milligrams once in a day, Zantac 150 milligrams once in a day, Lanoxin 0.125 milligrams once daily, Capoten 2.5 milligrams twice a day, Salsalate 750 milligrams thrice a day, ASA 325 milligrams once in a day, Ginsana 100 milligrams twice a day.
Is he allergic to any medicine?
No, doctor.
May I know his family history of illness?
Well, his father expired of a myocardial infarction at 70, and his mother died of complications of a dental procedure.
Well, his physical examination reports show blood pressure 157/86. Heart rate and irregular respiratory rate 12 to 20 breaths per minute. Reflexes are symmetric. Plantar responses were flexor, bilaterally. His cardiovascular regular rate and rhythm without murmur. HEENT shows abrasion over the right forehead. Extremity, distal right leg edema and erythema just above the ankle. Well, I have reviewed his previous HCT scan, which reveals a left parietal epidural hematoma. Right lower extremity revealed a fracture of the right lateral malleolus for which he was casted. I am ordering a repeat HCT scan to see if there is any change in the epidural hematoma. Upon seeing the reports, I shall suggest further treatments.
You hear a dentist discussing booking problems with her receptionist.
Hey Kieran, Mr. Lau just mentioned that he'd tried to reschedule his appointment yesterday, first online, and then when that didn't work, he called up. But apparently he couldn't reschedule. Any idea why?
I wasn't working yesterday, but let me check the notes. So, Lana left a note about the call. She says that Mr. Lau wanted to reschedule, but we didn't have any other appointments this week after 3 p.m., which is the only time he could make. He asked if he could make an appointment next week, but his procedure was marked on our system as urgent, so she had to make it in the same week. The system wouldn't have let her reschedule it any later. She wouldn't have had the authorization to change that. Still, she should have discussed this with you at lunch or at the end of the day, because then you could have decided whether it could have been postponed for a week.
Yeah. In his circumstance, it would have been fine to reschedule at a slightly later date. We should prevent something like this from happening again.
You're right. I'll talk to her about it tomorrow, and I'll send out an email to everyone else so that they're aware.
You hear a doctor discussing chest X-ray information with a medical student.
Hey, Dr. Yan, we've got the x-rays back from Mr. Regis in bed 8 from this morning.
Great. Can you document them in the notes?
Do you mind showing me how to write the interpretation properly?
Of course. Make sure you put the patient details. Full name, date of birth, patient number, and home address first. Then put the hospital and ward, date, and time. Make sure your name is on the document too. Include the indication for the x-ray like hemoptysis or dyspnea before documenting your interpretation. Now, I use a simple mnemonic to make sure I don't miss anything. A, B, C, D, E. Airway, trachea, carina, bronchi, and the hilar structures. Breathing, lung fields and pleura. Cardiac, heart size and heart borders. Diaphragm, position, shape, and costophrenic angles. Finally, everything else, the mediastinal contours, bones and tubes or devices. Make sure you document everything clearly using this system in the notes.
You hear an ENT surgeon talking to a colleague about cochlear implants.
We implant an electrode array which looks like several small wires made of a platinum iridium alloy into different regions of the cochlea. These metal wires conduct the electrical impulses generated from the microphone, which picks up sound from the environment and sends the signals to the electrode array through a transmitter. There's also a speech processor between the two that filters more important sounds so that the patient can hear people talking rather than other sounds.
Right, okay. So does this restore hearing to normal levels?
No. With the current technology, we're giving deaf people a good representation of sounds from the environment and help to understand speech. After surgery, patients undergo therapy to relearn the sense of hearing. Not everyone benefits from the device to the same extent.
Right.
You hear a GP talk about type 2 diabetes mellitus.
Hello. I'll be covering the diagnosis of type 2 diabetes mellitus. So there are 4 methods that we can use. The first is a fasting plasma glucose test. This is our preferred diagnostic test, as it's easier to carry out, often more convenient, and costs us less than the other 3 tests. It helps to try and book these appointments in the morning, as the patient has to refrain from eating for at least 8 hours before they can take the test. Normal fasting blood glucose will be between 70 and 100 milligrams per deciliter. A value of over 126 milligrams per deciliter indicates a diagnosis of diabetes. Bear in mind that this test should be carried out twice to confirm a positive result. The second method we can use is to measure the average glycemic load over the past 3 months.
You hear a dentist talking to a patient with a chipped tooth.
So we've talked about different options, and it seems like a veneer would be the best treatment. Given the cost of the procedure, are you happy to go ahead?
It's quite expensive, but I definitely need to get it fixed. Will it stay put?
Veneers tend to need replacing every 10 to 15 years, so they are a long-term solution. It will certainly be more durable than composite bonding, and it will look more realistic too.
Oh, okay. That's great. And is there anything I can do to extend their lifespan?
Well, you need to maintain good oral health. You know, brushing, flossing, regular checkups. You should avoid brushing your veneer too hard, as it could cause damage.
Okay.
You hear a podiatrist talking to a patient with fallen arches.
So, you say you're experiencing foot pain. Are you wearing supportive shoes?
I'm wearing appropriate shoes, and I'm also wearing orthotics that should be helping, but I'm still experiencing pain in my feet. Sometimes they feel a bit numb too.
Right, okay. And you mentioned that you've been given some foot exercises to do?
Yeah, the physiotherapist I went to showed me those. At first I thought they were helping, but now I think I'm as bad as I've ever been. Is there anything else we can do?
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It's been estimated that around the world there are millions of people who are otherwise healthy, have never had a heart attack or stroke, are not at high risk of bowel cancer, yet who take aspirin on a daily basis, convinced that it's going to help them. Well, the evidence from the largest ever study in this area suggests not. A huge trial called Aspirin, involving healthy Australians and Americans aged over 70, given low-dose aspirin for 5 years, has found no benefits and some harms. The research was led by Professor John McNeill of the School of Public Health and Preventive Medicine at Monash University, who I spoke to before we went to air. Welcome to the Health Report, John.
Thank you, Norman.
It's pretty impressive. 3 papers in the New England Journal. What sparked this study? Because it was Australian motivated, even though it occurred in the United States as well.
I think we've been aware since the 1990s that there's an evidence gap, that many millions of people take aspirin every morning, and the evidence base, particularly for those who haven't had a heart attack or a stroke or have no other medical reason to be taking it, the evidence just isn't there.
So what did you do in this study?
We recruited 19,100 people from the United States and Australia. 16,700 were from Australia, and we followed them for an average of 4.6 years, and half of them took aspirin and half of them took placebo.
And what were you looking for? What were your endpoints?
Well, the endpoint here was disability-free survival, which is a measure of how long elderly people stay healthy.
But how did you measure that?
By measuring how long it took for people to remain healthy without having a permanent physical disability or developing dementia.
And what did you find?
Well, we found three things. Firstly, low-dose aspirin did not appear to increase survival.
Disability-free survival or survival?
Disability-free survival and survival. And it also didn't prevent heart attack or stroke. I think I should emphasise that this study was done in people who'd never had a heart attack or a stroke, because people who have routinely take aspirin under very strong evidence to prevent them having another one.
So we're talking about healthy people recruited who were over 70 on average, is that right?
That's right. The average age was 74.
What about cancer? A lot of people take aspirin to prevent cancer, and there is some randomised trial evidence that aspirin can prevent cancer.
Yes, this was a surprising finding in our study. There were numerically more people dying of cancer in the aspirin arm than in the placebo arm. This was a relatively small effect. It wasn't statistically significant once we adjusted for the multiple comparisons that we were making, and it hasn't been seen in other large clinical trials. So we're suspending judgment as to what its significance really means.
And what were the complications and the side effects?
Well, we had the usual side effect of bleeding. We took a lot of care over the measurement of bleeding because older people are more inclined to bleed, and aspirin enhances that effect. And we certainly had an increase in hemorrhage in the people taking aspirin.
Now, previous studies have suggested, and we had this on the health report, I think it was last year, suggesting that if there was a hemorrhage risk, it was early on and that settled down later.
We looked at this, but we couldn't find that. According to our data, the risk of hemorrhage just kept going.
Now, we had a story not so long ago on the health report suggesting that the effect of aspirin, of low-dose aspirin, is actually only there in people who weigh 70 kilos or less, and that if you want to get an effect from aspirin, you should be on a higher dose like 325 milligrams or even 600.
We've had a brief look at that, and we couldn't find that in our older people.
What about dementia?
Aspirin appeared to have no effect at all on dementia.
But 4 years is not a long time to develop dementia. I mean, did you measure cognitive decline?
Yes, we measured cognitive decline very carefully, and we haven't analysed all the data yet, but certainly the number of people who were diagnosed with dementia was the same on each arm. But that raises a very important issue because we will be following the people who participated in Aspirin over the long term to see if there is a difference in incidence of dementia or cancer that appears later. And we know that there's been evidence that cancer preventive effect does take 4 or 5 years before it becomes evident. That's one of the reasons why we've been very keen for our Aspirin participants throughout both countries to continue to be involved and let us follow them up.
Now, if you have hemorrhage or you have side effects like gastric upset or something like that from aspirin, the people who are taking the real thing might have dropped out more than people on the placebo. That could have affected the results?
We did a lot of testing of how many people were taking aspirin. We counted their pill bottles and so on, and we found that basically there was very good compliance with the medication on both arms of the study.
Could this be a phenomenon of, as we are getting older, we're actually not necessarily aging, we're actually living longer, younger, and we're getting less heart disease? Was this population too young, paradoxically, even though they were 75? Were they actually too young to get an effect? Because 75 is like the new 50, as they say.
That's an interesting question. We followed people whose commencement average age was 74 and whose final average age was nearly 79. So that's following people through a reasonably long period. We had a number of people who were over 80 years of age, and as far as we could tell, there wasn't a really big difference between the impact of aspirin at any of these ages.
So if somebody's taking aspirin now, they're entirely healthy, they've never had heart disease, they've not had bowel polyps, which is another reason why some people might take aspirin to prevent the polyps turning into cancer or new polyps emerging, and they're on aspirin, should they just stop?
Look, we're not recommending this at this point. People taking aspirin take it for three reasons. I mean, some, of course, as you said, have had a heart attack or a stroke or something similar in the past, and they should definitely be on aspirin because the evidence is strong. And then there's others who've been put on aspirin by their doctors for a range of other reasons, and they should continue as well, certainly not stop without getting advice from their doctor. But then there's the third category who may have just decided, they've read somewhere, they're perfectly healthy, they think it's a good idea. The results of a spree will lead these people to reconsider whether that's a good idea.
Just finally, do we know the numbers of people who are taking aspirin unnecessarily?
We know that it's much more common in the United States, where about 40%.
The date's wrong.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Five years ago in Victoria, a baby died during a planned home birth. The coroner recommended an investigation into the extent of problems arising from home births. One of the results of this recommendation have just been published. A study comparing thousands of women having their babies in hospital with women having a planned birth at home. Miranda Davies-Tuck was the lead author. Miranda is a perinatal epidemiologist at the Hudson Institute in Melbourne. Welcome to the Health Report, Miranda.
Hello, thank you for having me.
Now you took data from 15 years. It's an impressive number of women.
16 years, 2000 to 2015.
Sorry,
inclusive.
maths was never my strong point. So you were comparing women who went for home births to women who went into hospital. What sort of numbers are we talking about here?
So there are around 4,000 women who planned a home birth and just over 800,000 who plan to give birth in hospital.
And we're saying planned because these aren't women who couldn't get to hospital and had the baby at home. These are women who just wanted to have a private delivery from a midwife.
Yes, so these were women who had made a decision at the onset of their labour to plan to give birth either at home or in hospital.
How did you do the study? What were you looking for and how did you compare the two sets of women?
So we use the routinely collected data that we have for Victoria. So every time a baby is born or a woman is pregnant in Victoria, a whole host of information is collected and reported to the Department of Health so that we can monitor the health of women and babies in Victoria. And so we access that data to compare the outcomes after we classified them as either planning to birth at home or planning to birth in hospital and whether they'd be deemed to be of high or low risk of having an adverse outcome.
So describe a pregnant woman who's low risk and a woman who's high risk. What sort of factors are we talking about here?
So generally speaking, a low-risk woman is a woman who has a healthy pregnancy. There's nothing majorly wrong with her or her baby. There's only one baby that she's carrying, so she's not having twins. And she hasn't had a previous complicated pregnancy, so one that's ended in a caesarean, for example. In contrast, the women who would be considered or who were considered high risk were predominantly women who had had a prior caesarean delivery. They were also women who were giving birth beyond 42 weeks, so we call that post-term. And then there was a smaller subset of those women that had more than one baby, whose baby was breech, so it wasn't head down, or they had some sort of serious medical condition such as hypertension, etc.
Okay, so like for like, but the difference was the home birth or not. I mean, was it truly like for like? I mean, were women having their babies at home more likely to be better educated, higher income?
Yes, so we saw that regardless of whether they had risk factors or not, they tended to be healthier, older women of a higher socioeconomic standard, if we use what we call CFA. It's a way we categorise them. It's not surprising though, because the women choosing a home birth in this study were doing so privately, so they were paying out of pocket to do that. The type of risk factors were slightly different too. So the high-risk women in hospital were more likely to have medical conditions, which was a little bit higher than the women who planned to give birth at home.
Before we get to the results, did that influence the results, do you think, or were you able to control for all that?
So we made the decision not to control for anything in this study. We weren't interested in the relationship between home birth and outcome, but what we wanted to do was to provide information in a way that women would be able to work out where they sat in that particular group and then make decisions about what their outcome rates would be if they did or didn't have risk factors and if they chose to give birth in home or hospital.
So what did you find?
So that we found that for the low-risk women, there were no differences in perinatal death. So babies were not more likely to die for women without risk factors planning to give birth at home.
So when you say perinatal, is that the first week of life?
So perinatal death includes stillbirths that occur during labour and also deaths in the first 28 days of life.
Okay. So no difference in perinatal death. What about other baby outcomes?
So in terms of some of the morbidities or the bad things that can happen to babies, some of these were actually lower for the women who plan to give birth at home. So their babies were less likely to have an injury and they were less likely to have some of the other morbidities that can occur. But this probably reflects differences in some of the intervention rates that the low-risk women, so they were less likely to have instrumental deliveries and caesarean deliveries, so possibly it could be related to that.
What about the high-risk women?
So for the high-risk women, we didn't see that the perinatal mortality rates was the same. In fact, we saw that...
You got a tripling, didn't you?
No, it was actually 7 times more likely to have their baby die if they planned to give birth at home. Yes, so neonatal death was So death after the baby was born was the death rate that was significantly higher in the women.
For what reason? I mean, there wouldn't have been large numbers, but what reason?
No, so the numbers were very small. We can. It's difficult to talk about the drivers of this because the numbers are so small. But it did look like the babies that were born at home were the ones that died. These were not the babies that transferred to hospital during labour.
So if we got into problems with a planned delivery and you transferred to hospital, you were okay. It was just if you got into strife, then that's the women who got into problems with their babies.
Yeah, and potentially there were barriers to the transfer to hospital. Whether or not those barriers still exist right now, we can't be certain.
But all the maternal benefits and the other benefits were there in the high-risk women. It was only that risk of perinatal death that was the issue. Now, there are all sorts of... So in other words, it's basically good news as long as you've got your risk assessed and you're going into this with your eyes open.
Yeah, absolutely. And it's really good that we've been able to show for Victoria what we already know for international studies. So the UK data has been telling us this for a long time, but we didn't have any data to inform us here. So it's good to see that what we're seeing here is the same as what they're seeing in the other big studies internationally.
Now, there are big issues here. Midwives are supposed to have an obstetrician who covers them, and they often find it hard to find an obstetrician who's prepared to cover the midwife and look after them. The midwife feels that they're not easily able to transfer the baby. There's a problem with payment and insurance, getting indemnity insurance. Are we overcoming those barriers yet?
Yes and no. I think certainly a lot of the barriers to transfer are decreasing. We have collaborative arrangements now where hopefully midwives are feeling comfortable backing up and consulting with obstetric staff when women need care. Certainly we see from the data that we have that when a woman has been identified as needing to transfer and transfers to hospital, her outcomes are fine. So in those instances, absolutely.
And just very finally, very briefly, because we're well over time, is this applicable to other jurisdictions in Australia, do you think?
I would say yes.
That is the end of Part C. You now have 2 minutes to check your answers.